Interesting things to help our comprehension today. It certainly help mine, and to help our, let's say, comprehension of mainstream media reports. But because we haven't done one for a few days, I just want to do a bit of orientation to see roughly where we are going and look at some problem areas, it has to be said, often neglected problem areas. So here we have the new daily confirmed cases. And these are always adjusted per capita for the size of the population, of course, otherwise there'd be little point showing them. So New Zealand, okay, levelish there. Canada going down, Australia going down slightly. Pretty good signs in Australia, actually. United States, well, certainly a downward trend in the United States. Slight upward tweak there, but an overall downward trend in the States, and the cases have gone down really pretty dramatically from this peak up here. Now, areas of concern here, Netherlands, just look at the increasing infections in the Netherlands diagnosed, very sharp rise. Likewise in Ireland, this is indicative actually of a few places in Europe, which is concerning as autumn comes. They're going to be having a very high sort of takeoff base for the later autumn, early winter time, which is the time we're most concerned about at the moment. So Ireland there, but then I'm afraid the United Kingdom is higher. Now, it looks like cases in the United Kingdom have dropped down quite nicely, and it looks like a bit of a trend developing there. But as we'll see in this video, this is almost certainly inaccurate, I'm disappointed to say. But we'll be looking at reasons for that, because we really have to question the official line sometimes. Now, moving on, number of COVID-19 patients in hospital per million, United States going down. This is roughly what we'd expect from the States from the reduction in cases, but the UK going up. Ireland, a sharp increase. The capacity of hospital beds, especially intensive care beds in Ireland, is limited, so that is a concern. Again, as we're going into the more risky time of year, it's not where we would like to see it in Ireland. Canada, Netherlands, much lower rates of patients in hospital per million people. Now, here we have new daily confirmed deaths. Now, the United States, the deaths have gone down really, it has to be said, pretty slowly, starting at the top there. They are starting to go down now because the hospitalisations and cases have been going down for some time. But we have to notice, still at a pretty high rate. No cause for complacency at all in the United States. Cases are still at a pretty high rate, as we can clearly see. Moving down, United Kingdom, Ireland, Canada, Netherlands, Australia, New Zealand. So trends there for deaths in the United Kingdom and Ireland, actually not that good. Definite upward trajectory in those places. Patients actually in hospital per million people. Now, these are the countries that mainstream media very often doesn't tell us too much about, the former Eastern Bloc countries, the former Yugoslavian countries. Very little interest in those in the UK media, very little interest in those in the United States media, and yet, let's see what we've got. I mean, Serbia, dear me. And now I've left Denmark in there. Denmark's pretty low. Patients in hospital per million people. So that's good. No surprise there. Ireland, as we've seen, picking up. UK picking up. But look at the size of the gap here up to Latvia, Lithuania, the Baltic states, and Serbia, really very high. Now, notice here we don't have data available, and it's not because I forgot to put it on. It's just not available at the moment for places like Russia, Ukraine, Belarus. The data's simply not available. But we do believe that things aren't good there at the moment. But those countries that are coming into the 21st century in terms of reporting, unfortunately, the reports are not good. Now, we do have new weekly hospital admissions for COVID-19 per million for Romania, where we don't have the number of patients actually in hospital. So again, Denmark, Ireland, United Kingdom, Lithuania, but then we see Latvia and Romania very high, and we believe that Moscow isn't too bad in Russia, but we believe that the more rural parts of Russia are pretty bad, meaning there's going to be unnecessary deaths. It's unfortunately as simple as that. Likewise, intensive care facilities are very limited in Romania. They've got a lot better since they joined the European community, but still limited. So Romania, very high number of patients in intensive care at the moment in Romania. Serbia, and then again for the context, Ireland, United Kingdom, Denmark, all way lower. So it's pretty obvious to me that there's quite a few people dying in these countries who unfortunately really don't need to, because of these high cases and hospitalizations. Now, moving on to the question mark I put over my government's data there. Here we have the official government data here, showing cases are down 12.5% on the week. Nice reduction. But we do notice that deaths are up quite a bit, over 1,000 in the past week. And we do notice that patients admitted to hospital are up a bit. Now, of course, we would expect the delay. But let's look at what we've got on this. So this is the official government data showing the cases are going down a bit. But then when we look at the COVID symptom tracker data, and this is for the same period of time, for October, for the same period of time, the COVID symptom tracker data is showing a continuous increase in people reporting symptomatic cases. And here we see the COVID symptom tracker data here. And we see it's gone up all the time. So clear contradiction between the COVID symptom tracker data and the government data site, and getting perilously close. That's the distribution in the UK at the moment. Getting perilously close to this 100,000 a day number of new cases, at least on the COVID symptom tracker data, if not on the official government site, which is only showing 43,000 new cases per day. So which one is correct? Well, we are in a position now to tell you. I am in a position to tell you which one is correct, because the COVID symptom tracker one is correct and the government one is not, I believe. And I'm going to tell you why that is. I believe that to be the case. Well, why I'm going to give evidence for that. Obviously, it's not my belief. So poor lateral flow test reporting. Now, a lot of people are doing lateral flow tests in the UK, but not as many are logging on and reporting it, so it goes in the official government figures. You see, it could be a bit of a hassle. You might not have the internet going at that time, although most people do have internet. It might be that you don't really see the point of reporting it. You've got a positive result, so you know, so no one else needs to know, really. Or so people might think. Or, of course, it's half term now. You don't want any inconvenience. So if one or two members of the family are testing positive and becoming minimally symptomatic, well, just carry on and enjoy half term as usual. So this could be the way people are thinking. I do hope not, but I think it probably is. And the other thing is that the government aren't looking for the right symptoms. Less than 50% of patients have the classical symptoms. So the government's missing about 50%, perhaps, of cases, because you need to have the official government symptoms, the so-called classic symptoms, to get tested. The continuous cough, the fever, and the loss of smell and taste. But 50% of people don't have those. They simply don't have them. So that's 50% that aren't getting tested. Now, is the government doing this deliberately? Is Dr. Jenny Harris, who is now in charge of was Public Health England, it's now it's got a new name now, Health Security Agency or something like that. I mean, is this what is it? Is it incompetence that she doesn't update the symptoms? Is it ignorance? Well, I don't believe it can be ignorance. Is it that the government doesn't want to see the cases to appear to be higher? We don't know. And of course, Dr. Harris is welcome to come on this channel anytime and explain the situation. But at the moment, it is unsatisfactory. There's no two ways about it. So I would encourage you. I've been filling this out every day now since the start of the pandemic. Do flick onto your, what do you call it? Is it the App Store or something, and download that and log your government, log your data every day, so that we have something to compare the government data to. COVID-19 symptom tracker app with Zoe and King's College London and Tim Spector. Now, this is from Tim Spector's site here. Top 5 symptoms in the vaccinated and children just happen to be the same. So headache most common, runny nose, sneezing, sore throat, and then a cough. And the loss of smell is 6 and the fever is 8. So the government is missing 50% of cases. And if you're not symptomatic, you're not going to get a government test. Therefore, they're missing all these cases. Therefore, we can conclude that the government data here is inaccurate and the COVID symptom tracker data here is accurate. So I think we're now in a position to mark this. So we'll just that's inaccurate there. So we'll just go to like 1 out of 10. And as far as we know, this is accurate. I mean, it's not perfect because it's symptom tracker data, but we'll give it a 9 out of 10. That's pretty good. So that's probably the most accurate up-to-date data we have at the moment. Of course, because when we compare it against so if you want an optimistic view, then go to the government data. If you want what is actually happening, or nearer what's actually happening, go to the Office for National Statistics, which we're going to see is consistent with the COVID symptom tracker data, or go to the COVID symptom tracker site itself. Now, let me give you the evidence for this here. So, Office for National Statistics with their nice viral logo that some of you say looks like a marine mine. Not for me to comment. So, Office for National Statistics here clearly supporting the COVID symptom tracker data. Check it out for yourself. Don't take my word for it. There's the site. Overall, coronavirus COVID-19 infections continue to increase in England in the most recent week. So they are going up. Clearly in agreement with the COVID symptom tracker data. Percentage testing positive, still highest in those school age 7 to 11. We'll have a look at that in a minute. Overall prevalence is increased in the weekend in the 23rd of October. So it is increasing. As we can see, it is certainly increasing. That data is pretty unambiguous there. And I will show you some more detailed data on this in a minute as well. That's also pretty interesting. Now, going on with the Office of National Statistics report. Well, the amount of infections high. 2% of the population in England, pretty well, 1 in 50 people. Was only 1.79% the week before, so an increase in England. Wales, very high, 2.56%, up from 2.31. Wales increasing in prevalence. Northern Ireland, 1.33, up from 0.76. Not as high as Wales, but still going up. Scotland, 1.36%, up from 1.14% the week before. And Scotland, of course, and Wales have more rigorous legally enforced preventative strategies. So they are not apparently working, or the effect has not yet kicked in. Probably more likely to be the effect has not yet kicked in. So looking at some data here from the COVID symptom tracker app in a little more detail. Now, these are new confirmed cases. And now this is interesting because this is in all people, and these are cases in the fully vaccinated. So we see a lot of cases in the fully vaccinated. Now, the difference between the two groups would be that length there, wouldn't it? Because that's everyone. And of course, everyone includes the fully vaccinated. But we are seeing a lot of breakthrough symptomatic infections in the fully vaccinated. Although the fully vaccinated group is now much larger than the unvaccinated group. So we do see that the vaccines are still giving a large degree of protection against symptomatic disease, but they're still happening to quite a large degree there, although there is more protection from hospitalisation and death, as we know, but still getting symptomatic infection, still transmittable, of course, can pass it on to others. Now, this is the incident by age group here. Now, this top line here is the 0 to 18, so this is the school age group. It's particularly high in the 11 to 18-year-old age group. They're picking it up in school and they're taking it home to this green age group here, which is their parents' generation. Slightly concerning to see some increase in the older age groups. This red line here, for example, is the 55 to 75. Quite an increase there. And they are, of course, at risk of being hospitalised. But this is the group that the booster vaccine dose is getting round to. But still a significant increase there that could give rise to more hospitalisations. And as we've seen, hospitalisations are kind of at the upper limit of where we'd like them to be already in the UK. Prevalence by region, well, we see a general increase in most places there. So the leader there is actually Wales at the moment. And this is the number of cases of long COVID that are developing based on these figures. Symptoms going to last for more than 12 weeks in 1,500 people a day. So 1,490. The error range there is 1,374 to 1,606 new cases of long COVID in the UK on the 23rd of October. So that's per day. So we do see that there's going to be this really quite significant burden of morbidity, unfortunately, for a bit of time to come. Now, going back to the COVID, to the Office for National Statistics data, this is the number of people testing positive for antibodies. 92% in England, 90% in Wales, 91% in Northern Ireland, and 91% in Scotland. Now, this has gone down a little bit. So this is somewhat down. It was 93.4 from memory, I think. So the number of people testing positive for the antibodies has actually gone down a bit as the antibody response is wearing off from people that particularly were vaccinated early on in the pandemic, early on in the vaccination program, who have not yet had their booster shots. Positivity has increased in younger adults, which we would expect because the infection's spreading to that group, or has been spreading to that group for some time. Shows sign of a slow decline in older adults. Now, this is not because less adults have been infected, it's because the immunity is, or not the immunity, but the antibody response is wearing off. Now, this is based on an antibody finger prick tests. Now, at the moment, I think they're doing about 100,000 of these every month. It's pretty impressive, really, but just a finger prick test. And what that means is this isn't a particularly sensitive test. So you have to have a fairly high level of antibodies in the blood. There's a threshold level of antibodies in the blood to get a positive test. So the test probably is missing some people who do have antibodies but just don't have enough to trigger the test. So that could be one reason it's going down. And this is a direct quote from the Office for National Statistics site. A negative antibody test does not mean that a person is not protected. Because, of course, we know we have the B cells and we have the T cells and all these other lymphocytes that protect us from viral infection. The B lymphocytes making antibodies, especially the memory cells, the memory Bs and the memory Ts and the memory T killer cells that will kill virally infected cells. And the natural killer cells that also provide a level of specific immunity to the virus. So antibodies are only one indicator, and how this is going to pan out in terms of future hospitalisations and deaths is not yet clear, but we are expecting a good degree of ongoing protection well beyond the time when the antibodies have gone down. So it's not a brilliant indicator, but it is showing the overall level of exposure to the virus. These figures are accurate. And of course, these are people who've had at least one dose of the vaccine and or have been exposed to the virus under natural exposure circumstances. And they're going to ramp this up to 150,000 antibody tests per month. So it's pretty impressive. And that's going to be every month for the next year. So we are going to be able to keep a pretty tight handle on this and get some pretty accurate information. Last thing I want to look at, we saw that deaths in the States are unfortunately high. Deaths between the 13th of March 2020, which is when people first started dying in this pandemic, and the 1st of October, which is basically as up to date as we're going to get for the Office of National Statistics. So this is basically the deaths from the whole pandemic. In the United Kingdom as a whole, there's been 119,869 deaths, excess deaths above the 5-year average. Now, that compares to 140,000 deaths on people that have been diagnosed within 28 days of a positive test, and 163,000 that have been on the death certificate. So what we see is that the actual excess deaths are quite a bit lower than these other two figures, meaning that some of these people would have gone on to die anyway, and a lot of these people would have gone on to die anyway. So I think this is the most accurate indicator of the number of people that have lost life from the pandemic. Still appalling, of course, but not as high as those figures would tend to indicate. Current UK deaths from the Office of National Statistics. Well, these are all deaths, not just COVID deaths. As we saw, the COVID deaths are around about 1,000 a week. 12,845 per week deaths altogether. But this is the key thing. That's the key point. It is 15% above the 5-year average, so that is still happening. Now, I'm just going to play you this because it's kind of interesting. It's from a doctor in New Zealand called Dr. Anthony Jordan, who's asked a rather brilliant question. So let's listen to the question and listen to Dr. Jordan's response on New Zealand TV, New Zealand radio, sent in by David sent this in. So thank you, David.
Hello, Steve. Thank you for calling.
Yeah, good afternoon. Can you hear me?
Yep,
Yes.
we can hear you, Steve. What's your question?
The question is about aspiration of the mRNA vaccine. I had mine done, but I had to go to my GP to get it done. And she advised that many people had come to that practice asking the same question. Now, there's been a peer-reviewed study in the States, and they've had a lot of people with pericarditis and myocarditis, over 100,000 serious hospitalisations, which they believe now is a variable from this. And there's also been studies in regards to the AstraZeneca and the thrombosis, and they believe that's the same way, that it's an accidental intravenous injection. Now, Pfizer states quite clearly, and I've read through their information...
Now, Steve, I'm sorry, mate, we just need in question form because we've got a lot of people on the line.
Okay.
So what's your question?
Why aren't they doing it here when Pfizer states quite clearly that it should not be done intravenously?
Okay.
And yet the only way you can tell is to pull back and aspirate the syringe ever so small to see if there's blood there.
All right, hold there, Steve.
Here we go. Dr. Jordan, did you get that?
It's an interesting thing. We don't traditionally aspirate back when we're injecting things into muscles, just because it's quite a blood-rich area anyway. Some people do, though, but it's not necessarily a requirement in intramuscular vaccination because, we all know muscles have a lot of blood in it anyway.
Yeah, great.
Okay.
Sorry about that. What an excellent question from Steve. Excellent question. Citing peer-reviewed literature, cut off. Guy didn't want to know. Not interested in peer-reviewed literature. Don't bother me with all this evidence, Steve. What are you telling me evidence for? And the answer from the... what was the title? Oh, doctor, that's right. The answer from the doctor. We don't normally aspirate when we give into intramuscular injections. Wrong, doctor. Wrong. We do normally aspirate when we're giving intramuscular injections. It's just in the particular case of vaccination that at the moment we are not. But other intramuscular injections that we give, for example, depot-phenothiazines, it's absolutely essential that we aspirate. So that's wrong. Now, the reason we don't aspirate is because it's a blood-rich area anyway. I think the next question might have been on the location of the olecranon process and the glutamus maximus, because to say the muscle's a blood-rich area anyway, therefore we don't aspirate, is such a non sequitur. Because if it was blood-rich, then all the more reason why we should be aspirating. So clearly you simply didn't know the answer. So, Steve, my congratulations on an excellent question. I don't know who Steve is, but if anyone does, please pass this on to him. He has my compliments on an excellent question. And, I managed to get this question to the Irish Parliament as well, the doctors there. And I heard their response, and we did play it on the channel, and it seemed pretty clear they didn't understand the question either. So when doctors don't even understand the question, I find that a little bit concerning. So there we go. That's a bit of an update, and I was going to say a bit of amusement from New Zealand, but it's not. It's absolutely tragic. So thank you for watching.